we will keep asking whatever in detail. So I don't know what exactly moderator has to do in this lecture because time is very little. So there is only 35 minutes for clinical case discussion. So I guess we have to be very brief and not interrupt as much as possible. So let's see. Let's start.
Sir, you do whatever you think is appropriate. The floor is yours, and whatever you deem appropriate, please go ahead. Yes, we should leave some time for diagnosis.
I think what I would intend to do is to generally, try and pick up learning points, whatever are there.
Yes, sir.
And I think the main thing here is more of investigation and decision making rather than presentation. But we will see what best we can make out of the story.
So what I would encourage you both to do, I mean, the faculty to do is to ask questions to the student panelists on how they could interpret some of those aspects, those learning points that you are raising.
Okay.
Go ahead, Sujata.
Good evening, everybody. I'm Dr. Sujata. I'm presenting a case. This is a child, 14-year-old girl, who is a student of class 9. She's hailing from a village in Kasaragod in Kerala. She belongs to a poor socioeconomic status and her parents are the informant. The chief complaints are that heart disease was diagnosed on day 3 of life. Then she had recurrent chest infections till 6 years of age. And since 6 years of age, she has restriction of activity. History of presenting illness. She's a firstborn child of born at term gestation. No history of any antenatal concerns. Birth weight was 2.4 kgs. She was born of a vaginal delivery. She cried immediately at birth and was roomed in with mother. Baby was feeding well and there was no history of hurried breathing or bluish discoloration noted. On day 3 of life, she was noted to have jaundice and she was shifted to NICU. In the NICU, she was diagnosed to have a heart disease. And the parents were told that she would need a surgery for the heart disease, and therefore was advised cardiology follow-up at a later date. However, when she recovered and she was discharged after 3 days of NICU admission, she was not started on any cardiac medications. Thereafter, she went home, and during the infancy, she did not have any feeding difficulty or breathing difficulty. And but during the infancy, child had poor weight gain. There was no history of bluish discoloration during the infancy. At 1 year of age, she had first episode of chest infection, which required hospital admission for IV medications. At 1.5 years of age, she was admitted for a diagnostic cath procedure. Details of the cath procedure are not available, and parents do not know regarding the cath the findings in the procedure. But after the procedure, they were not offered any surgery, and they were advised for follow-up. But they were lost to follow up, and she was also again she was not given any medications after at the time of discharge. She had 4 admissions for chest infections during 4 episodes of chest infections were there. The last episode was at 6 years of age. Thereafter, she started going to school. She had another diagnostic cath study at 7 years of age, after which she was again advised follow-up, and she was not started on any medications. She did not follow up with cardiologist after this procedure. The child goes to school, and according to parents, she studies well. She avoids playing with other kids as she tends to get tired easily. And this has been noted since 6 years of age. There are no symptoms at rest or with routine activities at home, like helping her mother in kitchen and getting ready to school or walking to school, which is close to her home. Parents also give history that child is not gaining weight like other children. No history of breathlessness, chest pain, symptoms of presyncope or syncope, palpitations. No history of bluish discoloration of lips, hands, and toes. There's no swelling of feet. 2 weeks back, she was re-evaluated in the district hospital, and echo was done, and she was started on diuretics, which is Lasix and Aldactone, both once daily, and she was referred to our hospital for further evaluation. Presently, she is admitted for the evaluation. Developmental history, she attained all milestones at appropriate age. Her vaccination history is up to date until 5 years of age. 10 years vaccination is not taken. And family history, she is the only child born of a non-consanguineous marriage. No history of heart disease in young in the family. Personal history, she has a mixed diet, sleeps well, bowel habit is regular, increased urination since starting medications, and she has not attained menarche. This is the history, sir.
Summarize. The next slide summary.
To summarize, this is a 14-year-old girl with heart disease diagnosed on day 3 of life, recurrent chest infections till 6 years of age, and restriction of activity since 6 years of age with poor weight gain. She has had 2 diagnostic CAT studies at 1.5 and 7 years of age on irregular follow-up, presently in NYHE class 2 and on oral diuretics.
That's fair enough. So how do we think around this? So our problem is, one thing, do you think the weight loss is related to the heart disease? Her dominant symptoms are weight loss, fatigue, etc., etc. So first thing first, you think she is grossly malnourished or whatever? Is it related to heart disease? What kind of heart disease gives rise to what kind of weight?
So I would, you can take this question, Sujata, but I would also ask the students from Jayadeva. Yeah. The students from Jayadeva and
weight loss, recurrent.
Dr. Kothari, your voice is not very clear.
There's the echo coming actually.
Echoing.
Maybe I have not 2 things on. Have I?
Now it's okay. Now it's working. At this point, it is working.
Little near to the mic.
Yes.
Yeah.
Now it's better.
So when does heart disease give rise to weight in difficulty in weight gain, or what kind of heart disease?
Yes, sir. Shunt lesions result in decrease in failure to gain weight, which could be because of multiple reasons in these patients, like recurrent infections, poor feeding.
She had no symptoms at all. Like for first year of life, she was not symptomatic at all. As much as we can say.
Yes, sir.
So you think that heart disease causes weight loss in her case? What about cyanotic heart disease? Do they give weight loss?
Yes, sir. They also they don't gain weight.
There is some say about height versus weight. That mostly cyanotic heart failure give rise to weight loss, and cyanotic heart disease do not really give rise to failure of weight unless it's extreme, unless it's very, very severe. Isn't that right, Dr. Subramanian? Anything related to this? Because I think in this story, I don't think we can blame the lack of weight gain on the heart disease. She never had any heart symptoms. Mother said she was feeding well up to 1 year of age. And most chest infections in a left to right shunt wouldn't occur after 1 year. They would rather occur before 1 year. So that is not really fitting very well. So while we are on that, how do we define recurrent LRTI? I mean, it's a common exam question.
Sir, recurrent LRTI is...
If somebody from one of the other students want to take up.
The respiratory infections, more than 2 infections per year or more than 3 infections anytime can be defined.
So this child could be said to have a recurrent LRTI perhaps?
Yes.
So what are the causes of recurrent LRTIs? Salina?
Sir, increased pulmonary blood flow leading to engorged pulmonary arteries which are compressing bronchus, and there is stagnation of secretions, as well as there is increased interstitial fluid. Because
I'm asking not the mechanism, the causes. A child comes to a pediatric OPD with recurrent LRTI. What are the things that you think?
Sir, apart from the heart conditions, sir, other like mucus secretion, like delayed removal of the secretion like cystic fibrosis or any immunodeficiency like condition could be the cause.
Absolutely. So you have to think of you should say first say lung disease, immunodeficiency, several other things, not only heart disease. Heart disease comes lower in the list if you look at the total patient population. And amongst the heart disease, left fraction is there. So the question of weight loss was important because when they can have weight loss irrespective of heart disease. I mean, not because of the heart failure itself. It may be coexisting genetic syndromes or whatever. So that is one part. The second thing is there are 2 cryptic caths done. Where were the caths done? Do you have any idea, Sujata?
Sir,
where were they done?
So one in Shri Chitra Hospital and one was in private hospitals, MIMS.
So then the simple question, I mean, in terms of thinking around, is it that when do you do a cath and do nothing after that? It's not a very medical kind of thinking, but this is what has happened in this case. So you done cath and you have not followed it up with anything. So how do you analyze that part?
So probably the heart lesion was a complicated heart lesion which was not amenable to a simple repair, and therefore.
So one possibility is it was too complicated to repair. Possible.
Yes, the other cause could be that inoperable for reasons like increased PVR found in the cath study.
At 1.5 years, which is more likely?
A complicated heart lesion.
Okay. Can I ask you a question? You tell me all the conclusions from the history. It was diagnosed at 3 days of life. No cyanosis.
And actually,
relatively well through the first year. What does it suggest to you?
Dr. Subramaniam, I'll ask you to direct these questions at the other students because Sujata has some level of familiarity. So I would...
the other one, Salina or Sham, I'm asking. I thought
Salina or Sham, yes.
I think Sujata can excuse yourself now.
Yes.
But the cardiac symptoms have not brought the child to hospital that time. That time there was a history of jaundice, could be incidental diagnosis of heart disease at day 3.
Yeah, no. That's okay. What does this history suggest to you? Diagnosed on 3rd day, relatively well at 6 years, till first year of age. What does it suggest to you? And no cyanosis. There must have been a loud murmur. Isn't it? Day 3 without cyanosis, heart disease detected means there must have been a murmur. That tells me that. If the patient went on to have uncorrectable heart disease later and relatively asymptomatic first year, so it's quite possible that the child had pulmonary hypertension very early on. Do you agree with that or not?
Yes.
Salina, yes?
Actually,
Yes, sir. But the child is having the features of increased pulmonary blood flow till age of 6, sir. So probably
when does increased pulmonary blood flow start manifesting in a child?
Sir, after the PVR reduces,
yes.
It won't present immediately. Once the PVR is reduced and then left to right shunt is established.
Yeah, generally when? First in the infancy.
Yes, sir.
Okay. Now, yes. Pulmonary hypertension patients also get chest infections, isn't it? Due to other reasons. Could they?
Yes, sir.
Yes. So my feeling, my conclusion at this stage would be probably the child had pulmonary hypertension very early on. Okay. Right. And 1.5 years cath that Dr. Sham said, most likely it was, as you said, it was pulmonary hypertension or complex heart disease. That's possible. Another feature in favor of complex heart disease was you are not started on any medication. No? 6 or 7 years ago, or maybe, I don't know, 12 years ago, if the patient with a simple lesion like VSD or PDA had high PVR at 1.5 years, I would have expected them to start sildenafil and see whether the PVR comes down. I wouldn't declare the patient inoperable at 1.5 years. So I think the fact that no medicines were started also suggests to me that it could have been a complex heart disease. Do you agree, Shah?
Yes, sir.
I thought, where is the cath done? So if it is looked at Chitra, I mean, you know the degree of how to analyze those things. But one more variable you should keep in mind is sometimes parents don't tell the full story, you see. Especially, suppose, and they have like, either they will try to say forget or they might rationalize. So all these things has to be taken with a pinch of salt, that they were told this or that. We can't take totally it on the face value, that nothing was told, nothing was given.
Just a guesswork.
On the face of it, it looks like she had either a complex heart disease and she probably developed pulmonary hypertension very early. Now, how often that happens that patient has no symptoms and end up as Eisenmenger first?
The students, would you want to take up that question? How often do you get a patient presenting as Eisenmenger syndrome without clear evidence of left-right shunt as the first presentation, as the early presentation? Does it happen? And if it happens, what is your approximate and what proportion of patients can actually result in this presentation?
And then how would it happen?
And also, which group of conditions are more likely to present like that?
Who's answering that?
So, Selina, Sham, Vinila, anybody?
Just guess. See, nobody knows the right answer. You can guess as well as I can guess.
Sujata, you want to guess? You want to take a...
Sir, it can happen. I would guess 10 to 20% of the times the fetal, the PVR doesn't regress because of the presence of the shunt in order to prevent the shunt symptoms. So
we don't know why it happens, but persistent fetal circulation just stays like that. It doesn't regress, as you rightly say. It may have many reasons theoretically, but it happens maybe less than 10% of the time. So mostly it doesn't happen. So I would say 10% maybe reasonable, less than 10% could be reasonable guess. And the other question was, Dr. Subramanian is asking,
which group of conditions that PVR cannot fall or does not fall or should not fall?
Post-tricuspid shunts like VSD.
No, even in VSD, the PVR does come down.
So now, Sujata, you should not answer. You will have a bias. I'd like this other students to answer this question.
I want Suman Raj, Vinila and all that. What group of conditions that the PVR does not fall or should not fall?
It's a very important question. Just think about it. Normally, the PVR just falls, but in some select situations, it does not fall. And it's an important list of, there are a couple of 3 or 4 possibilities, but 2 are really important.
Anybody, even the third years can answer.
Yeah, anybody can answer.
Saying TGA. Samrita has written on that. You can speak up. TGA is one answer.
Yeah.
Sir, in cases where there is some obstruction to the pulmonary venous return,
yes,
obstructive AVVC or pulmonary venous stenosis, or if we have got a large AP window. But again, the large AP window is rare because the PVR will has to first fall for the
first part is right.
Both these are still essentially PVR dependent flow. There are conditions which are where the systemic flow depends on PVR.
Duct dependent systemic circulation.
Which is that?
Coarctation of aorta, interrupted aortic arch, hyplastic left heart.
What is that? Coarctation of aorta?
The coarctation of aorta, interrupted aortic arch.
Yes. Okay.
Hyplastic
So that's an important group of conditions where the PVR cannot fall.
Okay, sir.
PAH dependent systemic circulation.
The other example would be children living in high altitude. They tend to have this presentation quite often.
Yes, very important.
Complete the list, it can happen in VSTPD also, occasionally,
yes,
for reasons which we don't know. But those are first, but then VSTPD can also do that. But we know that it was not VSTPD because cath was done and nothing else was done. So it's a complex heart disease, perhaps early PAH. From the story, we can say that. And we have to then go for one examination.
Okay, so can we go on to physical exam, Sujata?
Yes.
Sir, one addition to that list of non-regression of PAH is those some severe AS patients who does not have regression of PAH, where AS is also not severe and they have LV which is not good enough. So they continue to have significant PAH.
Yes.
So, and in those cases, we may decide to do a cath and we may not proceed with anything because we end up not adding anything by giving any treatment.
So you said
LVEDP.
So
pulmonary venous stenosis.
Those are like forme fruste of HLH, but they are not truly HLH. So there LV cavity is there, but it's having a lot of diastolic dysfunction. So in a way, it prevents that regression of PVR, and they behave like persistent PH till late in life.
Okay, sir.
Sir, one point.
Sorry, okay, go ahead.
Sir, actually, since this patient has got a significant failure to thrive historically, but we don't have the dietary history of the patient, whether the patient had a good dietary history, despite having a good diet, the weight gain was not adequate or had a poor appetite, that would be a very useful in this case.
Whether it is just other related malnutrition from a diet or from other disorders or from poverty simple, that is to be thought of, because it's not giving gross history of heart failure. So probably weight loss is not secondary to that, and there may be something else basically.
Yes, sir.
Great. Exam.
Yes, sir.
Yeah.
Child has a thin build. She's moderately nourished. She's sitting up on the bed, comfortable at rest, cooperative during examination. Her weight is 23 kg, which is less than third centile for age according to the IAP growth chart. Her height is 137, which is again below third centile for age according to the IAP growth chart. And BMI is 12.2. So she is stunted as well as malnourished. Head to toe examination, there is no facial dysmorphism. Dental hygiene is good. She is pale. There is no conjunctival suffusion. There is cyanosis present in both lower limbs, which is more than the upper limb. Clubbing present, more prominent in the lower limb. And there is no kyphoscoliosis or skeletal malformation. There is no pedal edema.
Okay, next slide.
Pulse rate of 92 per minute regular, normal volume and character. There's no radioradial or radiofemoral delay. Respiratory rate 30. She is tachypneic. SpO2 right upper limb 84%, right lower limb 76%. BP in right upper limb in supine position was 106/70. JVP is elevated 7 centimeter above the sternal angle. Both A and B waves are seen. B is more prominent.
Next.
Precordial examination. On inspection, there is precordial bulge. There is a hyperdynamic precordium. Apex is present in right fourth intercostal space, 2 centimeter medial to the mid-clavicular line. It is diffuse forceful but ill-sustained. Suprasternal pulsations are seen. There are right parasternal pulsations in second, third, fourth intercostal space, and also in left second intercostal space pulsations are seen. Palpable P2 is present. Parasternal heave is present. Epigastric pulsations of RV type, and there are no scars. On percussion, the right border corresponds to apex. The left border is 3 centimeter to the left of sternal border. Left second intercostal space is dull. On auscultation, S1 is normal, S2 single and loud, no S3, S4 or additional sounds. There's a harsh pansystolic murmur, grade 3/6, heard all over the precordium, best heard along the right lower sternal border in inspiration. There is soft, low-pitched rumbling mid-diastolic murmur heard along the left lower sternal border, 2/4 in intensity. There is no presystolic accentuation, heard best with bell of the stethoscope. There are no other murmurs.
So now we are in trouble now, because the hardest data is that there is a differential cyanosis, right?
Yes, sir.
So where do we call something as a differential cyanosis?
Sir, can you just come closer to the computer? Sorry, sir.
Finished? Yeah. So
go ahead, sir.
Yeah, let's have Suman Raj and Vanilla. Let them be on the.
Yeah. So we need to have you interpret this. Dr. Kothari was saying that of this, which is the most hard data that you're seeing staring at you? that you know that you should explain for sure in your diagnosis.
Hello, sir.
Yeah.
Good afternoon, sir. This is Vinila from MMC,
Yes.
sir.
Yes.
Sir, here from clinical examination, the patient is having stunted growth and weight loss is there, and her jugular venous pulse there is prominent A wave and B wave is present, but V wave is more prominent, sir.
You're not answering Dr. KK's question. What is the most hard data which you need explanation? That's what he asked.
Of the whole physical findings, which is it that really specific, in terms of something that you absolutely have to explain?
Differential cyanosis.
Yes.
So let's go on to differential cyanosis. When do we call something as differential cyanosis?
Yes, sir. There is cyanosis in the cyanosis more in the lower limbs than the upper limbs, sir.
How much more? By how much more?
In some area it is mentioned that 10% and some 5% it is mentioned, sir.
So in neonatal screening, what do we take?
10%, sir.
No, 10% would be pretty serious.
4%. Actually, I think 3 to 4. Somebody says 3, somebody says 4.
3 to 4.
Yeah. So which is to say that it is pretty important. So I would like to make sure that this is there. If I had a chance, I would like to do exercise and see whether this gap is worsening, decreasing, increasing, whether it is real. Because if it is wrong, then the whole thing goes.
So it is real because we've got a much higher differential at other times, sir. So in fact, consistent and high. Yes, it is very real.
So we can take it that it is there. So what does this mean, Shyam or Suman Raj? Where do we go from here?
See, one point I want to emphasize, guys, when differential cyanosis is so marked 8-10%, then you're nothing to worry. And generally in older patients, it is there or it is not there.
Yes.
If you're doing it in a neonate or a young infant, it's often an unstable patient breathing hard, and it often fluctuates. You check the upper limb and then you come check the lower limb. The two values could be quite different, even if they are supposed to be equal. Ideally, when you have very close values, you should have 2 pulse oximeters and do it simultaneously on the upper limb and lower limb.
Absolutely.
When the differences are small.
So to rephrase what you're saying, almost any difference between upper and lower limb needs to be respected as you get older.
Yeah. So why cyanosis was never picked up? I mean, they never told in the story so far that child had cyanosis.
Yes, sir, they didn't realize the parents.
So Shyam or Suman, what do you think of this? I mean, this is a marginal question, but how would you interpret that? You say it's 84-76, but parents never noticed that. What are the options?
There will be mild cyanosis which will be missed by the parents.
Well, this is not mild. That's what Dr. Kothari is saying.
Sir, level of hemoglobin.
Yes.
So it could be that child was anemic all through. She's so malnourished that she never picked up hemoglobin beyond, and so they under thing. Other thing is that they were so busy with their own life that they didn't pick up mild cyanosis. So that's also important to recognize. You see, there are different groups. So,
Sir, that second part won't be true because patient has undergone 2 CATs, sir. So they were somewhat busy in taking care of the patient, sir.
Doctors have picked up, but they have not picked up. Agreed. It's not that they are not taking care; they are taking care. That is the point.
Yes. Secondly, late and insidious onset, family think that is normal for the baby. Yeah, for the child.
Yes, exactly. They're used to that appearance.
Yeah, even the clubbing, they assume it is normal.
PD Eisenmenger means lower limb cyanosis will often be missed many times. It is not uncommon at all. But upper limb 84 is slightly this thing. So
even after medical examination.
Yeah. So can you have upper limb cyanosis in PD Eisenmenger? For Selina or somebody, upper limb cyanosis in PD Eisenmenger. Why should upper limb be cyanosed in PD Eisenmenger? Right limb, let us say.
Let's say right upper limb saturation. In fact, in this case, it is right upper limb. So why would you have 84% in the right upper limb in somebody who has an exclusive right to left shunt? Just pure PDA. Why should it? Can it happen, first of all? If it does, why? Somebody, one of the 5 students, 6 students, even the Chitra group can try and answer this one.
If I go off video, would it help them to remain on the screen?
Yeah.
Can I go off video then?
No, sir. We can actually make them. Can you have the view, Vishnu? Can you put them on the panel, the student panel, on everybody's views so that everybody can see the student panel? They will arrange it, sir.
Okay.
It can be done. Just click on view.
Aberrant subclavian. Okay, aberrant subclavian is right. What else?
But that's a little esoteric. You should take the more, you should take the more common ones. Aberrant right subclavian, yes, but that is a good example, but more common reason why you end up with upper limb. Yeah, so inside the heart, what are the common causes? ASD or PFO can be there. Stretched PFO can be there. ASD can be there. That can produce upper limb cyanosis in these situations. So that is actually the most common reason why you end up with it. Otherwise, you should think of something else inside the heart.
Like Paulwood series of Eisenmenger, he found this right arm blew in half of them. And there could be even severe PVR is raised much more, then some blood can go to right arm also. So it's possible even by pure alone PD Eisenmenger also. So shall we ask you what is your diagnosis with these funny findings?
Yeah, VSD is a more common association with PDA. VSD is a very common association.
Yeah. So Dr. Kothari is now asking the students to come up with a diagnosis. So we'll start again with the Jayadeva group. What's your diagnosis? Have you made a clinical diagnosis?
Given these findings, is it possible to make a clinical diagnosis? And what is the diagnosis? Because that is the whole crux.
So Sujata, you can display the next few slides which you have read out. The first, second, you haven't finished these findings. Dr. Kothari, you want?
Shall we ask the diagnosis or
shall we finish the auscultatory findings?
Maybe, so I can summarize the problem. The problem is there is dextrocardia with situs solitus. Agreed? Situs solitus is there, dextrocardia is there. Mild heart failure is there. PD Eisenmenger is there. Severe PH is there with PDA shunting right to left. And there is a pansystolic murmur, which is loud.
Are these findings suggestive of PDA? Are these findings suggestive of PDA PAH?
Alone. Or is there something else?
Auscultatory findings, are they suggestive of PDA PAH? I'm asking. Guys, more direct question. What does the second sound like in Eisenmenger PDA?
Correct. So the Jayadeva group, what is the second heart sound in Eisenmenger PDA? Salina?
The loud P2, which will be
split. That
narrow
split.
Normal split, sir.
So normal split is what Selina is saying. Vinila, you want to take a call quickly? Okay.
Narrow
split is Vaibhav saying.
So narrow split is when you're sitting on the fence. Narrow split is for all the fence sitters. I have never been, it's very difficult to be sure about narrow split.
It may not be wrong answer, narrow split P2, because in PH the split will be narrow. And if it is normal split, it can be narrow split. So I'll agree with that. In Bangalore, it is narrow split.
So in PD Eisenmengers, it's characteristically normally split. Okay.
Normally split. So, a single S2 is typical of a VSD pulmonary hypertension.
Right. So to repeat, single S2 AST, split S2 with normal split, as Dr. KK said, is PDA, and AST will remain. What is the AST split like?
Wide and fixed split.
Not wide, but fixed split, actually.
So between an AST which is Eisenmenger and AST which is not Eisenmenger, both are fixed, but Eisenmenger AST is narrow fixed, because certainly that is narrower than the otherwise. So P2 split becomes narrow in AST certainly, and in PDA is a normal and VST is a single. But again, I think this is, you should probably quote Paulwood that these are there in percentage of patients. So they are not absolute.
Yes.
They are helpful, but they are not binding. So you can potentially have a PD Eisenmenger with a single S2 also, if there is a differential cyanosis.
Absolutely.
So if there is a VST and PDA both, then what happens to the second sound? Then it becomes single. Just for sake of time, I'll say that then it becomes single.
Okay. What does your cardiac examination tell you about the diagnosis? Forget the differential cyanosis now for the time being. Cardiac examination.
What are the findings suggestive of? A pansystolic, a single S2, a normal S1, a pansystolic murmur, and low-pitched mid-diastolic murmur along the left lower sternal border.
So first is a wall reagitation murmur like TR murmur and flow murmur.
Yes, very good.
So hypertensive TR, normotensive TR. Sundaram, TR is hypertensive or normotensive?
Hypertensive.
So we can say from this exam that it looks like a hypertensive AV regurg murmur.
Yes, sir.
Yes.
Mild TR, significant TR.
Sir, hyperdynamic grade 3/6. Sir, moderate to severe, sir.
Flow murmur is there. So more than that.
You must use all the data. Elevated JVP.
Yes, sir.
Elevated JVP, very prominent pulsations on the right border, harsh systolic murmur, very well heard all over the precordium, and a mid-diastolic flow murmur. Everything points to significant TR.
Yes, sir.
Significant. So what are the causes of a pansystolic murmur in a cyanotic heart child? So if you can put those things, then you can draw one of them here. So here child is blue and he is a pansystolic murmur.
So who's going to take that? Any of the 6 students?
Isn't it? Mostly cyanotic child don't have a pansystolic murmur because they have ejection murmur of tetralogy types. So when they have a pansystolic murmur, there are only few possibilities.
There are essentially only 2 possibilities.
Like
one that we've already talked about. What is the second possibility?
One is TR, but people like Eisenmenger doesn't have TR commonly, but some of them can have. So if there is a right AV regurg, or the patient can have MR, when do they have MR? It's not difficult.
With
large ASD, sir.
ASD with MR, AV septal defect,
Yes,
or any other cause of MR, or a corrected transposition with a left AV regurg because of left-sided abstinence, or patient have a DORV with restrictive VST.
Yes, that's the second category. DORV with restrictive VST would produce a pansystolic.
So physiologically, child should fit in some of these if our findings are right. See, we are only arguing on the findings. So if you take those findings on the face value, then this is there any problem with this diagnosis that patient has a PD Eisenmenger and a TR? In the history, is there anything not favoring this finding, not favoring this diagnosis? Hypertensive TR, and that too, as Dr. Subramanian pointed out, what was probably was present early in life, should have given the heart failure to the child. The child did not seem to have a big heart failure. A PH with as TR is generally not so, not cardiac. That child would be really floridly heart failure. So that is making me suspicious that, damn it, there is something more happening around here. So we'll see from investigation whether we get more enlightenment or what.
Yeah, excellent discussion so far.
Can I ask a question? What do you think the murmur on day 3 was?
Murmur on?
Lovely question. What are the murmur on day 3, Dr. Kothari and all of us? Actually, we don't know. It's a great question.
No, we don't know whether murmur
I want Suman or Salima to answer.
Dr. Kothari, the murmur has to have been there. Otherwise, they couldn't have picked up heart disease.
They couldn't have picked up. What was the murmur in day 3? Anybody? Any guesses?
Regurgitant murmur.
Which regurgitation murmur? Don't talk halfway, please.
Yes.
I think neonates, most common cause of murmur in a PAC is neonatal TR. Neonatal TR is very common. That's one. Secondly, I wouldn't be surprised if there's something wrong with the tricuspid valve also, because the way the TR has, TR is not florid in cases of even Eisenmenger. In this case, the TR seems to be the very prominent finding. So I don't know, but definitely neonatal TR.
So one more thing we should keep in mind that if the patient has a PH and has a murmur, normally Eisenmengers don't have a murmur. But if there is Eisenmenger and a murmur, then you have to think LVRA shunt also. See, sometimes you can have LVRA which can give you a murmur which is irrespective of PA pressures. So you can
obligatory.
You can get obligatory murmur with the cyanotic. Well, a 3-day murmur may be just a problem. What is the commonest murmur at a 3-day-old baby?
Obstructive PSAS. PS, pulmonary stenosis.
Benign murmur, no? Of the kinking of
peripheral pace.
Peripheral pace sort of a murmur because of kinking of PA, they say, and which disappears, isn't it? Which is often not picked up, but yes, that is the commonest murmur.
Sir, I think we need to think a little more, sir. This doesn't look like a PDA-PAH because there is dextrocardia, single S2 maybe because of left and anterior aorta because we are having a left-sided pulsation. So, I mean, I want to ask the students, I mean, do you want to consider the possibilities which are being discussed, or do you want to have something more in the diagnosis?
Sir, one can be the L transpose aorta, that pulsation which we are getting, either it can be.
So what is the diagnosis then?
So
so what are these murmurs then?
It can be, sir, L transpose aorta with significant right AVVR. And there can be associated maybe intrapid aortic or coarctation, which is causing a PDA dependent systemic circulation.
We don't need to bring that. I think we may simply say that it is cytosolicis CCTGA. Left AV valve is regurgitating as well as stenotic, which is giving rise to this mid-diastolic murmur.
Yes,
and that still doesn't explain our elevated JVP, which means that even the right-sided valve is also having regurgitation, which murmur we are not hearing. And that also explains why the sound has to maybe single.
What do you do with the differential cyanosis? All this is okay.
Doctor,
what do you do with differential cyanosis? As long as differential cyanosis is there,
yes, sir. So PDA is there somewhere, sir, in the circuit, but the background, the intracardiac should be like this, no, sir. Otherwise, how do we explain?
That is absolutely correct, because cytosolitis dextrocardia, you have to think of LTGA.
Yes,
but with LTGA, what? And in total context, what? Like total context means there is a PDA which is right to left. So if there has to be PH or arch interruption or coarctation. But even there, PH is there.
Sir, I would say CCTGA, VSD, with maybe some PS, may not be some PS, because we are not hearing that murmur. That may be behind aorta, maybe because of that we are not hearing it. And then in addition, there is a left-sided AV valve, which is a problem.
So few things which are clear is that likely LTGA with the right AV valve problem.
Yes.
Very likely. But in context of a PH with the right to left shunt. With or without coarctation. So that's so much we can say from examination. And let us see whether investigation confirm.
Let's go on to the investigation because it gets more interesting now. Okay. So let's move on. So we've got X-ray. We need this to be carefully interpreted. Can you display it? It's quite nice actually, but please display and interpret this X-ray. Maybe
I'm scared. I think I want to ask Dr. Tharkan or Dr. Subramanian to interpret this X-ray.
Sir, I would first ask the students. The students have to interpret.
Third year students.
Third year, maybe we can start with anybody. Any of you? Yes.
So this is the X-ray. It's an PA view X-ray with adequate centralization and adequate exposure. We can see that there is cytosolitis. The hepatic shadow is on the right side. The gastric shadow is on the left.
That's okay. That's okay. Go on. Go on.
Yes, sir. Go on.
Yes, answer coming to the cardiac effects is like not clear. We can take this as the cardiac effects and make it a dextrocardia. But it is not quite clear. It is almost equal on both sides, but this is a bit more on the right side.
Okay.
And there is no the cardiothoracic ratio will be around 52%. Just no significant cardiomegaly. There is normal pulmonary blood flow. There is no reduction.
You want to say, is everything okay with the pulmonary blood flow? I mean, there's two elements to interpreting.
So the peripheral pruning, sir, might be there. There's end-on vessels.
Okay. Do you want to comment on what are the two things that you comment on in an X-ray as regards pulmonary vasculature? One is the pulmonary blood flow. Another thing where X-ray is really useful is okay. Now, can you please tell me and look at this X-ray and tell me if is there a prospect of pulmonary venous hypertension in this patient's X-ray?
Sir, cephalization is more like not seen in this case.
Are you sure?
Cephalization.
Curly lines. If I move systematically, is dextrocardia there or not there? First thing first. So this X-ray is a case in point. You see, in medicine, we often find one thing pointing to one side, other to other side. So we have to take one of them. Now your clinical examination is saying dextrocardia. Your X-ray is suspicious. So is dextrocardia there or not there?
Is a clinical is there?
If somebody is palpated the apex clearly on the right and certainly on that, then we have to agree shadow can be any type. The dextrocardia should be there.
Yes,
so we'll take that. So if we say cytosolution dextrocardia, we are increasing chances of correct transposition. With the other heart disease, without other heart disease. So let's look at the lungs. Increase vasculature, decrease vasculature, or normal vasculature.
Increase, sir.
Clearly increase vasculature, no doubt.
Yes.
Now, venous hypertension or no venous hypertension? Probably venous hypertension. And doubtful venous hypertension, not very sure, because that is important in this particular case. Because if you have venous hypertension, we can understand the story a little better. Now, is the RA enlarged?
So the right sided atrium, if you are considering that this is the apex of the heart.
Right. Very right. As you say, we are not very sure how much is the atrium, how much is the apex. So there is a problem there. Is the aorta L post?
Yes, sir. It's a more left arch. So L post.
Possibly aorta L post. And since there is a differential cyanosis, is the PD could be there? PA is posterior, PA is not anterior. Is there a coarctation? Like is there a rib notching?
No, sir.
So there is no rib notching. So these are the findings to my mind. This probably shows dextrocardia. Now, how do you say apex? By diaphragm. Normally you say apex not by shape, you say by diaphragm. So here the problem is diaphragm is low on the left side.
Yes, sir.
Isn't it? So
yes.
So what to make out of that now? Apex by our finger we think it's on the right side. The X-ray says diaphragm is low on the left side. Where do we go from there?
What does that suggest? That actually points towards something. It's a very, very beautiful observation. When the X-ray shows a substantial cardiac salute on one side and the palpation shows it on the other side, what is the likely reason for that?
Not sure, sir.
So the reason is that the heart is rotated in the axial plane so that the apex points forwards. Much of the ventricular mass is lying anterior. That's when you get this kind of appearance. Otherwise,
So when you go to this data, the diaphragm pointing to apex, you find that 95% it works out. 2-3% it doesn't work out even normally also. So then that is not the hardest data. So therefore we insist that the heart is on the right side. No, apex is on the right side. Apex. So is it dextroversion or dextrocardia? So
Verted heart.
What is the difference between dextroversion and dextrocardia?
It will depend on in the dextrocardia. The apex forming will be on the right side, and
dextroversion.
Dextroversion, it is the like normal apex which has been noted.
Why don't you describe the atrioventricular axis? That will give you a better idea. No? Atrioventricular axis, base to apex axis.
Yes, sir.
In dextrocardia, what happens, and in dextroversion, what happens? That's all.
Sir, in dextrocardia, the axis is maintained, but in dextroversion, the axis is rotated.
Yeah, base to apex axis will be towards facing the right.
Yes, sir.
Right? In dextroversion, it doesn't. The entire axis just shift to the right. The direction is not towards the right. You get my point?
I think it goes by the axis of the base of the heart to the apex. Now the lower diaphragm on the left side is very suggestive of a normally placed ventricular mass on the left side. My guess is that segmental arrangement probably would mobile on the right atrial, the right-sided shadow is all dilated right atrium. Yes. Therefore, it would be something like a central heart with the apex pointing forward. That's what is more likely. And of course, the superior mediastinum is wide and the left upper cardiac border is wide. You could say that it's a dilated malpost, L malpost aorta. Yes, it's possible.
I think the apex may be on the right because it is palpated by finger. I will not discount that at all. So can the ECG tell us whether it is dextrocardia or not dextrocardia? We will go to the ECG. Maybe that will clarify it better.
Sure.
So our problem here is whether the right side is apex or an apex is on the left. We are not very secure, but there is increased QP, there is L post aorta, and there is a dilated RA.
The other thing is, whenever you have a very large pulmonary blood flow, you almost always have some pulmonary venous hypertension because the pulmonary veins are often prominent, but you rarely get pulmonary edema except in infant and curly line. So some degree of upper lobe veins being visible is acceptable in the case of left to right shunt.
Ordinarily, we would not mind that too much, but here we are looking for something odd. So we are thinking, giving a hard look, could there we find something which is making him, not symptomatic from birth? Could there be additional reason to have PVH?
Tell me, is there any other evidence of pulmonary venous hypertension
in this patient? No?
Yes, I'm asking the student. What would you look for?
Sir, we look for curly lines.
No. Out of the lungs. You look for LA enlargement. Nobody has talked of LA enlargement still.
Yes, sir.
Sorry, it's very important. I forgot. Yeah.
So what about the carina? What about the left bronchus?
Carinal angles are around 80 degrees.
Yes. Enlarged or not?
Bit split. No, sir. No, sir.
The LA does not suggest significant pulmonary venous hypertension.
One thing more I should have pointed out also is that because we are looking for heterotaxy also, are the bronchi looking similar?
No,
because,
sir.
One cause of histocardia should be heterotaxy. So it's not really, bronchi are not very suspicious, but I'm not sure. Somewhat you need some, I have some suspicion that they look like bilateral left-sided. But
so the right bronchus is short and straight.
So let's move on, sir, because we're losing time. Let's get into the ECG.
Sorry, yeah, let's go to ECG. Just tell me one thing, ECG, how do you diagnose dextrocardia by ECG?
So we will look for the P wave axis and the QRS axis.
P axis, Q axis tell you so many other things, but if I want to see heart, right chest or left chest, Selena, I just want to see heart, right chest or left chest.
The R wave progression and dominance of R wave in AVR. R wave progression in precordial leads.
So here, what are you saying? Here the R wave is regressing as you go V5, V6, and so I see my thinking is R by S, R plus S in V5. If it is more than in V1 or V6, V6R. So you look at the sum of R plus S in right side and left side, that will give you the ventricular mass, irrespective of other things. So here the suspicion is that V1 is R plus S is taller than V4, V5. The heart seems to be on the right chest from this ECG. And the other question is about the Q waves. So are we looking at LTG or no?
So the ECG is showing sinus rhythm. The P wave axis is around plus 45.
Yeah.
And so it's a sinus rhythm. And with a PR interval of around 160 milliseconds. QRS duration is around 80 milliseconds. In lead 1, it's a splintered QRS. It's almost biphasic. But the negative portion is slightly more than the positive. And AVF
is northwest axis.
What's a QRS axis?
Northwest axis.
You should tell exactly how much.
Okay.
You told me about the sinus rhythm, isn't it? The Q axis is normal, so it is sinus rhythm. There is, of course, right atrial enlargement because of those peak P in lead 2. Yes, and V1 doesn't suggest left atrial enlargement as such. And axis, QRS axis now?
Minus 260 degrees.
No, not minus 260. I don't know what is minus. It's minus 90. It's minus 90 degrees.
Yes.
It's almost equiphasic in lead 1. Yes. Right? Equiphasic in lead 1. And what about the septal activation? All these are important now.
So the septal activation, so there are tall R waves in V1, and also we're seeing deep S wave in V1 and V3. And in
septal activation. Septal activation is
in one AVL and V5, V6. So septal activation is normal direction.
Normal septal activation, isn't it? So corrected transposition and all probably don't come in the cards. Then, of course, ventricular hypertrophy. Ventricular hypertrophy.
So when the question is reframed, X-ray was suggesting LTGA, ECG is not suggesting LTGA. What shall we take? LTGA is there or not there?
Which is more reliable, ECG or X-ray? For corrected transposition.
ECG. Septal activation.
Well,
anyway, very good QS. I would vote for normal septal activation. We don't have the right-sided chest leads. Unfortunately, with all that heart mass on the right, whether it is right atrium or otherwise, but we don't have right-sided chest leads. Know how much of right-sided ventricular voltages are there.
Yeah, actually, I think I asked Sujanta also to give right-sided.
Obviously, the electrocardiogram is quite clear. It is situs solitus. There is a atrioventricular concordance. Probably right-sided ventricular hypertrophy. Left-sided, we are not very sure.
So LTGA or no LTGA? I would think that since everything fits with LTGA, I would discount this because this QA as a marker is often not there, especially when you have ventricular hypertrophies or superior inferior hearts or spatial misalignments. So situs solitus with extracardia, when the heart is doing funny things, you could still have LTGA with these Q waves.
I agree. I agree. I think
cytosolitis is extracardiac character transposition and everything else. Left side AV valve is not what I fitted in. ECG doesn't go straight for it. That's all I mean.
From the student point of view, it is safer to say they are normal septal activation. Therefore, I would think LTGA is unlikely. That's safer. But
I think that's the correct. I would agree with Dr. Subramaniam's because that lesson needs to come out. That learning point needs to come out. Even however, all of them have their limitations, X-ray and ECG. But I think this point is very important.
However, since the segments are all messed up, maybe messed up, I don't know. Then I agree the ECG is unreliable as any other thing.
But textbook says septal Q wave sensitivity specificity is in the range of 60-70. So you could have very well cases of LTGA where your Q is not what you expect. Now, how about LTGA and cytos?
To be very frank, I'm quite happy with the electrocardiogram rather than the X-ray. Maybe I'm wrong.
X-ray is very
more comfortable. Now,
I think we'll move on, sir, in the interest of time, because we have so much more to show you guys. So I would, at this point, we don't have a consensus, but I think we should go on and look at the imaging data.
Fair degree of consensus. Our diagnosis is LTGA with right AV regurg, which is seen in 40% of LTGA, with a PDA with right to left shunt. Now,
but Dr. Taragan has clearly ruled out LTGA, so we have some disagreement here, and we have to acknowledge the disagreement. Dr. Taragan is very clearly saying that he would trust ECG, and the others feel that LTGA cannot be ruled out, and it's a nice thing to hear, because it just shows how far we can go with physical exam, history, and ECG and X-ray in terms of trying to get very precise about the diagnosis.
I think any other cause, before we just open the cat out of the bag, is there any other possibility like common atrium causing cyanosis and something else causing, so are we looking at something else also? Is there some relationship causing more cyanosis? And the goofy thing is right to left shunt. Now, can we have a right to left PDA where we can do something? We can do something only when there is a mitral stenosis. So if there is a differential cyanosis with PDA and where something more has been done to the patient, I would worry that maybe there is some mitral obstruction or something which we can tackle. So my feeling is this is LTGA, right AV regurg, with something to the mitral valve.
I have a question on the X-ray. Can I see the X-ray for a minute?
Let's see the X-ray again. It's important. It's one of the most important investigations. Because this is, I remember having looked at the X-ray, and I can you show the X-ray? Yeah, that's the one.
Do you think this X-ray suggests you have Eisenmenger syndrome?
Not at all. Not like that.
What is against it, students? I mean, straightforward PDA, PAH, and that sort of thing I'm asking.
What is it not like? Why is it not?
Prominent tendons.
MPA is not prominent.
You don't see big PAs. You don't see big PAs. Okay, this is not the X-ray of Eisenmenger. The other thing is that
you could be hidden behind.
Pulmonary artery is not in its normal location. That's also possible.
So I would want to draw attention to this X-ray for a few things, because I interpreted it differently when I was shown this the first time. I interpreted it as significant pulmonary venous hypertension. And I interpreted it because of the background haze, the reticular appearance, the prominent pulmonary veins which are seen in the upper lobe, and peribronchial cuffing, which you're getting to see in the left hilum particularly. So I remember having been shown this X-ray in this patient after the initial clinical evaluation, and my interpretation was that of pulmonary venous hypertension. I was in some ways less biased because I didn't have such a detailed history at that time and physical exams. So I just looked at the X-ray in relative isolation, and this was my interpretation. I think I just wanted to bring it up at this point of time. But yes, this is an interesting X-ray, of course. Can we go on to the imaging, sir? We have a lot to do, a lot of ground to cover. Dr. Namnita, you need to start the image, your sharing screen and show the images.
Oh, yes.
And we're going to ask the Chitra folks to start interpreting quickly. Okay, I think you guys are very capable. So let's go on to slide number 20, Navneeta.
Yes, sir.
Yeah.
Yeah.
See, and you put it on slideshow mode. It's still slideshow, isn't it? Okay, fine. All right, just interpret this. There are selected frames that we're showing you. We're not going to show you the whole echo because they're not of good quality. Navneeta, you can take over completely, please.
Okay.
So it's a subcostal view, and here we can see that there are two good size ventricles with a large VSD, which is extending to the outlet, and the this vessel which is curving upwards. It appears to be the aorta because of the formation of arch and lack of bifurcation. So
Excellent.
That is communicating equally to both the lower ventricles.
Superb.
Okay. Anything else?
And here this might be the pulmonary artery that we're not very sure on the
Okay,
right
that's
of
okay.
right
Within
of
Within the cardiac salute, are you able to, actually the images are not that clear, Navneeta. I can't blame him beyond.
Okay.
It's not as clear on the screen. So maybe we can go on to the other images and then we can have them interpret also.
They are trying to tell you about AV valves.
Yeah.
Yeah.
But we'll show you better pictures. We'll show you better pictures. Go on. Just ventricle and cross section.
So this is a still image, not a moving image.
It's not a moving image. Why don't you go on to 22, slide number 22?
Okay, so this one item.
This one, sir, AVVR this is.
Yeah, or
Interpret the whole thing, please.
Sir,
run it, Navneeta, please run it.
Step by step.
So it's apical four-chamber view.
Yes.
And we can see that there is around like moderate to severe left AVVR.
And before that,
you have to see below that.
Regarding the AV valve.
Turbulence is the pulmonary veins are entering into the left-sided atrium. So there are also some turbulence is seen.
Okay, that's fine. But do you want to look at the AV valves more and comment more on the AV valve?
The grayscale is not actually.
Yeah, actually, it's not. Navneeta, I can't blame him.
Okay.
The images that we are seeing is not great.
Okay.
It's looking like
at least
balanced AVCD.
At least you should comment
If we
upon
cannot
where is the origin of this turbulence.
Yeah, that's very important.
Where is this turbulence
and the
coming
direction.
from? Yeah, where is it?
That you should comment.
Sir, it is coming
Navneeta,
from the.
go on to slideshow mode, Navneeta. You're not on slideshow mode.
Okay, sir, 1 second.
Play, you just go to you just hit the play on top and you'll get it. Because what is happening is you're getting to see all the slides. Hit play. On top of the screen, there is play. After add slide on the topmost panel, there is play. You press that.
Yeah, okay, sir, I'll do that. 1 second.
What is the origin of this color? Sunam? Why is there color?
Okay, let me share the screen and show you these images because that will make it easier. I think if you can't share it, Navneeta, I'll do it for you. I'm just getting down to sharing this because I think it's easier if I see it because I have a feeling there's some problem with what you are showing. So I'll just quickly go to that presentation and I'll share it for you and then that will be easier for you to see.
In the time it is being projected for students who were answering, focus on that where it is coming and then I can give you a clue that it relates to what Dr. Krishna Kumar was telling of an accident interpretation.
Then the second pulmonary obstruction.
Okay, are you able to see this now?
Yes, sir. Yes, sir.
So you can now you can see the images a little better. I'll try to make it brighter. I think what has happened is that we've lost the brightness.
Grayscale, sir, is bit.
Yeah.
I don't blame you at all. I mean, I'm so sorry about that. I'm not able to make that brighter. At this point, this is the best I can manage. These patients did have very poor windows. Don't worry, there are other imaging modalities which will compensate for this.
But what is striking here? Come on, you can say that from this image. So what is striking?
There's a turbulence which is starting at
wait. Before color, you got to comment on black and white or whatever you're seeing. Don't go to color straight away.
So there appears to be a common chamber to which the pulmonary veins
what is the size of the LA?
LA, sir, is smaller as compared to the RA.
Yes. And as compared to the LV also.
Yes, sir. And this is like looking like a quadrilateral like membrane.
No. Don't diagnose now, please. Describe it.
There's a membrane like partition which is dividing the LA into two parts. And the turbulence is starting from this point of the communication of this chamber to the LA.
Okay.
And
what is that round shadow on the lateral side of the LA?
So the CS, the coronary sinus will not be here.
What lies behind the LA?
Pulmonary
artery?
Vein, sir. Pulmonary veins.
Pulmonary vein. Why is it so big?
Probably it's a common chamber. It is draining into a common chamber.
I know, but why are the pulmonary veins dilated?
Because it is obstructed.
Yeah, say that, yes. So the color jet appears to have a neck, and probably the proximal veins are looking dilated from what I can see here. And what is this color? You cannot say there is turbulence and all. Those are all non-cardiology terms. You have to use appropriate terms when you describe this.
What kind of flow is it? Just use the word. Describe the flow. What's the nature of that flow?
Continuous flow.
Yes. Okay.
Continuous, all right. But what do you call this color pattern? Mosaic pattern. Mosaic with some aliasing. Okay. Okay, go on.
So we got the next image of the Doppler.
So it's a continuous wave for Doppler. It is showing that there's a gradient at the level where the pulmonary vein enters the common chamber, and it has got a gradient of 30 by 22. So there's clear-cut obstruction to the.
Okay. The other feature to suggest obstruction is that it's a continuous flow. It's not phasing.
Yes.
How much can be there in normal pulmonary vein? Suppose pulmonary vein unobstructed with a VST. How much flow could be there?
So the gradient will be more less than 5, sir.
Less than 5 now. See, in a VST high flow, no obstruction in the pulmonary vein. Pulmonary venous flow can go up to even 16.
Okay.
But that will be phasic, nicely phasic. So bigger sign of obstruction is flat. So whenever it is phasic, it is may not be obstructed with high flow. So, but this is way out. 30 is certainly very high.
Yes,
okay. The evidence is also there, so we can put everything together. Go ahead.
Sir, Navneeta, you can start talking because I'll show the next slide. We can, of course, have the interpretation made. Somebody wants to take a go at it.
So here we can see that it's a contrast CT. It is the coronal section. It is showing situs solitus, and the drainage of the IVC to RA is not clear in this view. We have to go to the other sections. So here we can see that the apex is on the left side. It's the LV like forming apex, and there is a outlet VSD. Here we can see this is probably the aorta.
Don't use the word outlet. Are you sure you can say outlet? What is the word really? Outlet is something else. But anyway, okay.
Subaortic VSD.
Who palpated the apex?
The student palpated. I also palpated, Doctor. Sir, I will show you in the end a video of what I thought of the precordial pulsations. But
okay.
I can empathize with the students' inability to exactly identify the apex.
So Dr. Tarkan was right in ECG interpretation here, because we went only by what she said. Somebody says apex is under my finger on the right. So I would say so be it, but this doesn't seem to be the right interpretation.
No, I think apex, everything, physical exam, everything has its limitations, and it really, this case serves to illustrate those limitations also.
Yeah. Lovely.
And so the PA is also seen, it is dilated. Origin of the PA is not clear in this view. And on the right side, we have a cardiac chamber which is being filled by the contrast, but we are exactly not sure what this chamber is.
Sorry. I will ask you, which is that chamber? Anyway, you can at least take a guess. Is it atrium or ventricle?
Atrium, sir.
Okay. So in which case?
Or the common chamber which you saw on the echo, maybe just taking a guess, not sure.
Now I think you want to take a call about this particular section.
Yes, sir. Here
to see the veins.
Yes, sir. Here we can see that the IVC is draining to the right-sided atrial chamber. Hepatic veins are also draining to the IVC, and here we have the posteriorly placed atrial chamber, and we can see that the left upper pulmonary vein, left lower pulmonary vein are draining into it. The right upper pulmonary vein is joining with the right lower pulmonary vein to form a common chamber first, which is then draining into the posteriorly placed LA.
Now you can take over and tell us exactly what happened, what is the diagnosis, etc.
Not yet, sir. Ekoda or images. I'm just showing you. Can you interpret this quickly? This is
Yes,
similar
sir.
to the echo.
This is the axial section. Here we can find that there is one if only this image was shown, I would have told that the apex is on the right side, and other chambers are not very clear. This is the left.
But this illustrates something below, isn't it? The
common chamber, sir, where the
also illustrate the pulmonary venous drainage. Where it gets into the atrium, and the obstruction is very well shown.
No, wait. The pulmonary venous obstruction is separate on the right and the left pulmonary vein, isn't it?
Correct. Absolutely, sir.
No, it's not a common chamber which is stenosis.
Absolutely, it is individual pulmonary veins that are. Yes, this is pulmonary venous stenosis, not called choroidal.
So one more thing.
Individual. Yeah.
This cut is slightly higher up. So this would not be the place where we should be talking about whether it is a right-sided cardiac mass or left-sided apex. We have to be having a lower cut. This is at the level of base, atriums. Okay, we have to have the cut at the level of ventricles, to say what you were saying.
Okay, sir.
Okay, here are two more views that illustrate the PDA, so you can just look at it. I mean, I'm trying to.
Yes, sir. On the sagittal view, we can see that the PA is enlarged, and it is giving rise to a PDA, which is continuing as the descending thoracic aorta. And on the left side, again, we can see that this is the PA, and the PA, from this, the PDA is arising, from which the left common carotid is arising.
Okay. So this is what I drew of the heart as the final picture. Do you want to integrate it all together?
So the IVC and the SVC.
No, you just say what's the full diagnosis now. Complete. Put it all together.
Sorry, describe the arch again. I didn't quite get it. What did you say?
Sir, here we can see the complete arch is not seen here. What we can see is that there is a PDA which is the left common carotid that is coming from the PDA segment.
No, that's not true. No. That's not adequate interpretation.
Yes,
not.
I think you should interpret it like this. The left plane is like RAO view of your angiogram,
Yes, sir.
So you are just seeing the PDA, which is like then connecting, and then you are seeing the RPA segment. So that is the part of the arch which you are seeing. So you don't over-interpret it rather.
Yes.
And left is like a lateral view angiogram, where you are seeing predominant filling of the PDA and the lower DTA. Upper part of the arch is not seen. So you again can't interpret on that. I think before sir goes on to the cartoon, AV wells, I think we haven't seen or they could not interpret on the echo. So that part of the piece.
No, we actually didn't show you good enough images, Saurabh, with all due apologies. They were very poor quality because patient didn't have windows.
Yes, sir.
So we, of course, had TEE at one point, but I haven't been able to capture that also and show it to you. But clearly there was an AV valve, common AV valve.
Sundaram, are you sure the arch is continuous with the descending aorta?
So the PDA, sir. The PDA.
Arch, I said.
Arch, sir, we are not sure from this view. Probably interpreted aortic arch.
No, you cannot say interrupted aortic arch. You're making that mistake because your RAO film clearly shows that the origin of the PDA. So from that, you can be pretty sure that the ascending and descending aorta are connected, but it's a difficult frame. I would.
Because the PDA is coming from, it doesn't come. Sorry, I lost power. I'm working on battery now, so you won't see me. Okay. Okay. Yeah, I agree. It doesn't look like interruption, but we're not seeing the continuity of the.
We will show you more images, sir. We will show you more images where everything is seen together. So this is the picture that we have based on the reconstruction that I drew. I was asking actually Navneeta to present. Unfortunately, so I had to show these slides. So this is what we have on the echo. There are a few more images that Navneeta has in her presentation. I think that she has updated, which will enable us to see that. So Navneeta, are you able to share your screen now? I'll stop sharing, so you can show those.
Okay, it's a common AV valve?
Yes, it is a type C Rastelli common AV valve. Large inlet VST which extends to the conoventricular region. Great arteries that are parallel, and there is a significant subpulmonic infundibular stenosis. There is a large PDA, and there is pulmonary venous stenosis involving all four pulmonary veins that sort of come together on each side and then drain with a very severe stenosis. This picture is what Navneeta was going to show you, where the infundibular sagittal vein.
Right, the AV regurg is on the right side?
The AV regurg is more on the right side, severe on the right side. So Navneeta, next image.
This one. Yeah. So this is another finding that which actually we couldn't pick up on the echo, but was picked up on the CT, where there were infundibular muscle bundles as well. So here we can see that although it's not like a great picture, there were some muscle bundles in the RV outflow tract.
So it's a tetralogy with AV canal.
Yes, tetralogy with AV canal with chorioatrium and large PDA.
Good Lord.
So this is where we stand, but now we have beautiful 3D recons of the whole thing. You can see the arch continuity. Navneeta, you can present and interpret for me, please.
Yeah, so this is looking at the heart from the posterior sort of aspect, where we can see that the pulmonary veins coming and joining together to form like sort of single channels on either side, and then there is obstruction on either side as well.
There's one more beautiful 3D recon. Can you show that? You can see the dilated pulmonary veins.
Yeah. I think I got only one in the presentation system there.
Okay, that's fine. No problems. Also, you can see the continuity in the arch. So that is also seen.
Yeah.
So that's the diagnosis. Can we now ask, maybe we can still ask the Chitra group, what would you do next? And then we can have a discussion from the experts, and then we can share some more data.
This patient has got severe PAH with probable pulmonary vascular disease and pulmonary vein stenosis. So probably we have to do a cardiac cath to look at the PH versus the PVR ventricular function and to assess whether at all this will be a surgical candidate.
So I couldn't. I'm going to restate what you said because you were not clear. From what I understood, you said that there is pulmonary hypertension, there is likely elevated PVR, but there is also pulmonary venous obstruction. Yes, so for that reason, you would like to do a cardiac catheterization to understand the actual numbers and calculate the flows and resistances.
Yes, sir.
Okay, thank you. Is there anybody, so we can show that because in the interest of time, we'll maybe discuss that. So here, I think you stop at the slide, Navneeta, and we should just have you dwell on this diagnosis also. No, go back previous, so that I think the group of students may want to read this and understand the diagnosis given the complexity. Okay, thank you. So let's see the CAT data. So now again, I'm going to ask the students, maybe Chitra can take a break and maybe the guys from Jayadeva, you want to just interpret this CAT data? Selena, just look at the oximetry run first and tell us what you interpret on the oximetry and then we can look at the pressures.
So the saturation in the aorta, sir, and descending aorta is 78. So it's a cyanotic heart disease, sir. And SVC saturation is 43, 47. There is a left pulmonary vein 97, RPA 77. From ascending to descending,
not too much of a difference, really. That's true. Okay, now interpret what is your interpretation of the oxygen oximetry? You have aortic desaturation.
Yes.
So, anything else you want to say at that level? In terms of what's the nature of the circulation that you're dealing with? How do you interpret?
Pulmonary vein, you have aorta, everything. You want to comment?
You've seen the number below. It's been done for you. It shouldn't have been done, but we did it for you. We are giving you a QP-QS ratio of 1.7. Yet you have severe systemic desaturation. Okay? How do you want to put that together? How do you put those two facts together? What is the physiology when you have this situation of significant desaturation in the face of a increased pulmonary blood flow?
Low cardiac output.
No, that comes much later. That's not what you need to say. What is the fundamental physiology here?
Admixture physiology.
That's important that you identify the physiology first. Okay. Now, would you like to...
The QP is higher and QS is lower. What does it suggest to you in simple terms?
So in simple terms, not just admixture physiology, a little more precise than that.
Okay, mixed venous is 40s and PA is 78. What does it suggest to you?
Mixed venous and PA both are
No, mixed venous is around 40s and pulmonary artery is around 78, 79. That suggests there is a step up.
Yes, sir.
Okay. And pulmonary vein is 97 and aorta is 77. What does it suggest to you? There's a step down.
Yes, sir.
Okay. So why don't you call it a bidirectional shunt?
Yes.
Keep it simple. No? It's a bidirectional shunt. However, the QP is clearly bigger than the QS.
Yes.
Okay. You happy with that?
Yes, sir.
Okay.
Since you are interpreting that, can you put it as low cardiac output? If yes, why? If no, why? You said low output.
Yeah.
Do you think
You said that on base. What determines low output?
Sir, oxygen saturation SVC IVC is very 43.
Yeah, but then that is in the context of an aortic saturation of 78.
Yeah, you have to look for the arteriovenous oxygen differences.
Right.
So that is not as low as you would have expected if aorta was 98 and SVC was 46. That would be lower cardiac output. Here it cannot be so low. So it may be low normal. The arteriovenous oxygen difference is around 40.
Yes, sir.
Normally it should be about 30. 30 is good normal cardiac output. Less than 30 would be, more than 30 would be borderline cardiac.
So the message is, don't look at the SVC saturation mixed venous in isolation. Look at it in context of the system itself.
Arteriovenous oxygen.
It's a difference that really matters. The difference is slightly higher than normal. There is some reduction in cardiac output, but it's not the most striking thing that comes to your. Okay, now to interpret the pressures, because we should move on in the interest of time. So I will start from above. Look at the femoral artery pressures.
Artery 120, diastolic 145. So there is a diastole means pulse pressure is high. Difference is there.
Yes.
LV 110, 12. Okay. Pulmonary 29, 18. RP wedge 30, 17.
Okay.
MPA, sir, and RPA, it's high, sir, both like not suprasystemic.
So you got an LA pressure of 6 and a pulmonary venous pressure of 24, right? And a RPA wedge of 26. Maybe they couldn't enter the right-sided pulmonary vein, they entered the left-sided pulmonary vein. Okay, then go on.
Ascending and descending, sir, no much difference.
No difference. Okay.
Yes, sir.
Do you want to know the RV pressure?
Yes, sir. Is any outflow?
You fell into the trap, huh?
You got a huge VSD.
Yes, the same, sir.
Okay, why? I mean, yeah, okay, go ahead. Interpret the pressures.
The ascending and descending are same. There is no differential cyanosis.
Yes, that's the point, sir. On cath, we didn't find the differential cyanosis that we were expecting to find.
On echo, is the duct shunting left to right or right to left?
Difficult to say, sir. Poor images. In fact, we couldn't even pick up the PDA properly on like we just suspected vaguely.
Is there a lot of PR? Pulmonary regurg is there? Although the valve is narrow, is there a PR?
No PR. No PR.
So in the absence of the PR, a wide pulse pressure would suggest that the duct may be shunting left to right. If there is no PR.
Correct. There might be a net left to right, but it's again, to be honest,
because majority of the desaturation is driven by PS and admixture rather than PVR. That would favor, X-ray would favor that actually, but that would be difficult to say. At 14, what we are saying is that duct is shunting left to right, or it is not massively right to left, if this is to be believed. This is on room air, no, not on oxygen.
This is on room air.
Room air.
Yeah.
The other important finding, it tells me that the RV outflow muscle is not really protective.
Yeah, it is not protective because the duct is massive.
That couldn't protect with a massive duct, but that duct should shunt right. If the duct is also shunting right to left, then how are we saying that he is operable? He is protected somewhat, protected by 24. Now, is that protection enough? Now, that is, we are coming to those questions now.
Yes, that question is to be answered by the faculty.
Yeah.
At this stage, I'm going to ask the faculty what should we do next.
So I want to know how much is the right AV rigors? Is it bad enough?
Severe.
So potentially she will benefit at least by decreasing the rigors, separating the circulations, and putting a fenestrated patch. But see, the pulmonary vein we may not be able to do it too well, although they are ostial and we probably should do because distal pulmonary veins are not bad. So I think we can offer a palliative surgery with some guarded prognosis. That's my thinking. I don't know what Dr. Subramanian, Dr. Thakkar says.
I'll go through, I'll listen to all three of you, sir. Dr. Subramanian, Dr. Taragan, Dr. Saurabh Gupta. What are your thoughts on what you should do here?
Well, I'll just tell you, overall, I do find that pulmonary blood flow is probably a little more than systemic blood flow. And there is severe pulmonary venous hypertension, though a diastolic to pulmonary, which, what is it called, that diastolic pulmonary gradient, it's quite high. So PVR is elevated, maybe around 8 to 10. But always when there is pulmonary venous hypertension, always give a benefit of doubt to the patient. Because some of the patient may not have actually pulmonary vascular disease. So pulmonary venous hypertension does protect it from the stage 3 to 4 of pulmonary arterial hypertension disease. So if you could relieve the pulmonary venous obstruction and allow flow, I think intracardiac repair with fenestration should be a possibility. So with high risk and guarded prognosis, but of course you should obviously provide for some right to left shunt if the pulmonary artery pressures don't come down. The RV outflow obstruction, obviously we don't have the data. It's only anatomically shown as hypertrophy. Probably I wouldn't think it is much, but we never know. Maybe some resection there. But the AV canal defect itself may be difficult for correction. I do not know whether that's AV canal defect.
Excellent, sir. These are superb, sir. This is exactly in the lines we thought. Dr. Subramaniam, sir?
Yeah, I agree with what Dr. Taragan, Dr. Kothari said. Whenever there's pulmonary venous hypertension, you don't write off the PAH. I agree. But then this is not a common garden situation like mitral stenosis in DOR. Mitral stenosis is a much more simpler condition. Here we have a combination of a complete AV canal defect, which itself is a PAH producing condition. And then we have a huge ductus. And then we have pulmonary venous obstruction. It's not simply ostial obstruction. It's an elongated obstruction extending into the pulmonary vein. It's not going to be easy to relieve it and prevent recurrence. So I wouldn't assume that she is operable. I would probably suggest that relieve the pulmonary venous obstructions and then look at the hemodynamics again. Intracardiac repair is a very, very major decision. Repair 2 AV valves, repair the VST and PDA in the setting and pulmonary veins. And you're asking for fluids. Yeah, I would relieve the pulmonary vein obstruction, wait a few weeks, whatever, and then reassess the hemodynamic. But doing everything at one go, too much. 2 AV valves, AV canal defect, PDA and pulmonary vein obstruction, the surge. Each one is a full operation by itself.
Wonderful thoughts again. Saurabh Gupta, Dr. Saurabh?
Sir, I feel it's a quite complex case. And as everybody else has said, I won't be thinking straightforward for a complete correction. I would be rather thinking if PDA is the cause of too much of a problem, we tackle the PDA, try and do AV valve repair and relieve pulmonary vein obstruction if that is possible. But with the experience which we have had with the pulmonary venous surgical thing, it doesn't yield very well. So I don't think we should be going in for a complete repair. Again, the second thing is about that RVOT obstruction. I'm not very sure that is as such protective because we haven't seen in terms of anatomically how narrow is that. Whether it will protect the patient if we close the PDA and it will allow reasonable blood flow and patient will not desaturate further. So if that part is reasonable, then I would think of PDA closure, PDA ligation and AV valve repair and pulmonary venous without touching the VST.
All wonderful thoughts.
I just want to add one thing that it's a very malnourished child. It's a bad thing. But I would say it's a one-time job, either this or that. I think I'll go for it properly. I said it's a very malnourished BMI 12. It's a very bad thing. But the child would either we say it's operable. I think she should stand a single stage everything. But provided we recheck the pulmonary veins, are they really ostial? Can we do a good job? The key question is that. Otherwise, see, rastally AV canal TOF they can manage. Surgeons are doing a good job, right? AV valve, if it's tackleable. It's a severe recurrence. I think go for it once and leave a fenestration in the VST.
But actually, I have a question. If there is RVT which is protective, and if we do a balloon occlusion of the PDA and see what happens to the PA pressure,
No, it is not protective. I mean, protective protection law is lost when there is a large PDA. There is no protection to pulmonary vasculature now.
There is no protection. And the second, PA pressure is high. It's the same as RV pressure.
No, that is because of the large PDA, sir. Large PDA is changing the equation.
It is shunting into the aorta. So, I mean.
Yeah, it is like, a case of AP window pathology of failover.
Yes, sir.
The pressures are systemic. That means the systemic PA pressures are due to the AP window, while RV outflow stenosis is severe. You mean you're trying to tell something like that? I don't know. It is muscular hypertrophy of the RV outflow is there, and I don't know whether it will clamp down and protect the pulmonary circulation after the ductal closure. I'm not so sure.
What was your impression of the RV outflow obstruction? Was it severe on echo?
Sir, so I'll slowly let the cat out of the bag. On the echo, we were not seeing enough. On CT, it was not stated clearly at that time, but there was Mahesh, our expert, pointed out, I'm concerned about the RVOT. So I'll tell you then what happened. We sat and we've had so many meetings on this patient and so much discussion. But I think Dr. Kothari's reasoning was what prevailed after knowing this family, that they had disappeared for follow-up repeatedly and they were not coming back. So we also reasoned that there's just one opportunity out here. We won't get another one. So after a lot of deliberation, we went ahead, and the surgeon also wasn't happy in doing a half job of anything. He wanted to either fix it or not do anything. So we then chose to do the full correction. I went to the theater because the TE had to be done. And the pre-op TE, I got significantly concerned about the RVOT obstruction. There just was no clear pathway in the transgastric view. We were able to see a lot of muscle. Then we went back and looked at the CT. We really never found a clear path between RV to PA. So there was a lot of muscle that the surgeon had to resect. The surgeon found pulmonary vein stenosis, which he did a fantastic job in repairing. Really completely laminar flows resulted. He did a repair of the type C AV canal and was able to clearly close the VST, close the AST with a fenestration. And the VST patch also was able to close it all the way across to separate the fibrillate arteries. Repair the AV valve, almost eliminate the AV valve regurg, the very mild regurg that remains. And AST, not VST. He said he was not comfortable with the idea of a VST fenestration because of the complexity of the patch.
I think that is not acceptable. If you go in this setting, you must fenestrate VST. Anyhow, or you leave a small PDA.
Yeah, so the idea was to leave a small PDA, but the PDA was humongous. It was, in fact, we talked about leaving a PDA as a potential option for a so-called pot shunt. The PDA was gigantic. He said, I can only get rid of it. I can't constrict it because it was coming in the way of subsequent surgery. In any case, she did fantastically in the first 24 hours. The PA pressures declined and was down to a mean of 29-30 as against the systemic of 78-80. In the first 20, we could extubate her next morning. There was a lot of talk. I kept saying, let's extubate her 2 days later. But the anesthetist in the morning reported that, these numbers look superb. There's no reason to ventilate, and he extubated. We continued to monitor PA pressures in the next 3 days. And we found it was labile. It was labile. There were times it would reach near systemic, but then it would come down. There was also a very significant relationship between the lung signs. And the child had a lot of lung signs post-operatively. And whenever the pulmonary situation would worsen, she would have pulmonary hypertension. And if we were able to do a good pulmonary toilet, make her cough, it used to clear up to some extent. She still has a lot of lung signs even now. It's going to be a little hard to figure out, but eventually after about 3 days, we managed to get a PA mean of less than half systemic consistently, and we shifted her out of the ICU. She was fantastic in terms of symptoms. She really was not having any problems whatsoever. We did an echo subsequently, and I think she will show you, Navneeta will show you. We are getting better images now for some reason.
Yeah. So this is the post-op echo.
Show those apical view. That's very nice.
Yeah. So
and then, yeah.
Yeah. Regurg is minimal, and the pulmonary venous flows are very laminar.
They were completely laminar.
Yeah. No residual pulmonary venous obstruction.
And then the next one you can show, but there is some pulmonary hypertension even now. I have to be, I mean, it's not, it's definitely probably around half systemic. So there is pulmonary venous hypertension.
How did they repair the pulmonary vein? Was it a sutureless repair? Sorry?
Repeat that, Navneeta, we're not able to hear you. So they cut back. They cut back on
the pulmonary veins on either. Till the individual veins, they did not actually do a real sutureless one. The veins were big, so they managed to just repair it without the sutureless.
So here
they excised the stenotic segment.
They excised the stenotic segment. They cut back into the pulmonary vein significantly and produced what looks beautiful. I agree about your concerns about the likelihood of recurrence. What makes me somewhat optimistic is the massive size of the pulmonary veins. Unlike when you see in babies and newborns where you're worried about pulmonary vein stenosis, the individual pulmonary veins were of the order of over a centimeter in size. So the final orifice that I saw on the echo in the OR, in the T, was that on the right side, the left side, we had an orifice of 12 millimeters. On the right side, we had an orifice of 9 millimeters. On the left side, we had 9 millimeters. The right side, we had 12 millimeters and completely laminar flows. That made me feel very happy. But I agree, I do share a concern. I asked the surgeon to leave behind a sizable fenestration in the event that we have to, do something in the cath lab subsequently. But at this point, it looks very good. I completely share your concerns. We don't know because at this age, even though the sizes of the veins are big, that's something which we are not sure about. So that's what we found. All throughout, I have to say that I have given her dual pulmonary vasodilators. Right from the day. Yeah, I gave, she is on 20 milligram thrice daily of sildenafil, 5 milligram daily of ambrisentan, and we will continue that because I have my doubts and I share all the concerns that you are all stating, and I am also not sure. I'm also concerned as to how she's going to do eventually with all this. But she looks terrific. Can you show the next slide, Navneeta? I mean, she just looks fantastic now. She's standing next to her mother. Can you run that video? That's just to show you that epicardial pulsations. Is it running, Navneeta? Oh, it's not running. That's all right. But we could see the pulsations in the, there you go.
Sir, what was done to the RVOT, sir? Do we have a patent valve?
Yeah, fantastic valve. Lots of muscles. No problems on the valve, but the subpulmonary muscle tissue was resected considerably. So that was more like a cannal type situation only.
So we have an intact valve, no, sir? That would be good.
The pulmonary valve is completely intact. There is no PR whatsoever.
Yes, sir. I mean, that is something good. Otherwise, we would be facing a situation of PAH with PR, which would be much difficult to handle.
No, it will be difficult to handle, but the way she flew off surgery gave us a lot of good feeling in terms of her overall, at least initial phase, we are feeling happy about it.
Because the post-op PA crisis is the only concern where we could lose that potentially. So they see fenestrating a patch should not be such a big deal. No? I think
so here is
4 to 5 millimeter VST.
No, I know, but we've been doing this. We've been looking at this subset, and we've discussed this extensively, and we've had lots of. I used to be equally adamant on fenestrating the VSD patch, but in this particular situation, the surgeon really didn't feel comfortable doing it. Now, a PA crisis we hardly ever see with the current post-operative management.
In this patient, you saw PA pressures going up and down. One of them could
up and down, but that does not qualify as crisis. Crisis is when you have PA pressures that go to the suprasystemic range with a simultaneous decline in systemic.
Yeah, lucky that everything has gone well, but fenestration should have been a reasonable thing. Anyhow, all is well that ends well. This is fantastic.
No, it's not ends well. It's not ended all right. So, I mean, since it is ended, so at least the early post-op is good. We have to watch and see. But I completely agree. The jury about fenestration, whether should we have done the surgery, all the questions are very open even now. I don't deny that, but I think it merited a very careful discussion.
Only thing is, after looking at the X-ray, I asked again: Is there a dextrocardia? And send me the right ECGs, because if you tell dextrocardia, then thinking goes to LTG. But ECG was telling that it is not LTG. X-ray is staring at you that apex is on the left and it is down. But if you tell me that no, I palpated the apex on the right, then what can you do? You have to argue on that only. But it's
I agree.
It's a wonderful learning experience, actually.
Yeah, I think it's a wonderful case and even better result. But I would be very interested for learning sake if you can do a cath after 6 months or 1 year.
We will, sir.
Let us know the progress.
We will absolutely do
that
it,
will be a good learning exercise.
Yes, sir. We will do that, sir. For sure, we will do that.
Sir, as has been highlighted multiple times throughout the discussion, sir, such a patient remains a challenging case. And I think for the benefit of students, the message they should take is if you decide to operate such a patient, do a very, very meticulous follow-up, because after 3, 4, 5 years down the line, they may become sick. Correct. And I think Dr. Kothari will remember a case where we operated a VSD where there was a tight pulmonary vein stenosis. And that patient was 15 years, did well for 3 years, and then started having downhill goes despite pulmonary vasculitis. So these patients are very, very different from any other child with VSD PAH at say 3, 4, 5 years of age. And that should be kept in mind.
Oh, certainly. We absolutely recognize that.
Great. Okay. Nice.
So we have time for the quiz.
If the students are up to it, I'm happy to show the quiz. So can we, Vishnu, I will show the quiz here, and at the same time, you can run the poll questions.
Sure, sir. Sure.
So I'm going to start sharing the screen and show this quiz as we, just give me a second. I'll be on the quiz in a minute. So we will, in the interest of time, not try and spend too much time. We'll do the audience poll and we will take the opinions of the August faculty. So here's the first question. Which of the following conditions is most likely to be inoperable? Okay. So here's a 10-month-old with Down syndrome, AV canal, and a resting saturation of 92%. Then second question is transposition with unrestricted VSD in a 4-month-old infant with a resting saturation of 81%. And C is a replica of our case. And I can tell you, don't assume that we got it right this time. So so VSD with a quarter atriatum and pulmonary venous hypertension and a resting saturation of 85% in a 12-year-old. And a large ASD in an 18-year-old with a PA mean of 56 millimeters mercury and a resting saturation of 91%. So can we run the poll so that we can show the poll questions? And you can pick up the poll. You can read it right there and choose your answers. So we'll give you about 10-15 seconds to interpret this. All right, I think we should look at the answers. I'm very interested. Well, so I'll have Dr. Subramaniam give his interpretation and the context and the audience what you see.
I think the most number of responses have been for the large age old with the PA mean pressure of 56. That seems to be the most likely answer because in ASD you don't expect the PA pressure to go up. I don't expect it to go up at 18 years. Now, transposition with the VSD at 4 months. Well, many centers in fact operate transposition VSD at 3 to 4 months only. So that is not correct. I mean, they are very much they will not be considered inoperable at this stage. Large VSD and coordinatum severe pulmonary venous hypertension we just discussed. Well, you could take either way. As you see, we had a divided opinion. And AV canal defect, Down syndrome, 91%. Large septal defects are known to cause mild desaturation. And therefore, I think that's not really a contraindication for surgery. So I think the real answer is the large AS in an 18-year-old.
Thank you. Let's go to the next question. Here is more of a general question. Which of the statements regarding operability is incorrect? Okay, age is important. Benefit of doubt to younger patients. Unrestricted post-tricuspid shunt beyond infancy are likely to be inoperable. Lung, airway, and ventilation issues can elevate PVR and confound assessment. Pulmonary venous hypertension can result in reversible elevations in PVR. So you choose the most appropriate answer to this question, recognizing that I've deliberately brought in some ambiguity here. But I would want, because, I think you can choose what is most appropriate to this question.
You don't have none of the above and all of the above?
I see, that's one thing I've stopped doing. I learned about this MCQ rules. That none of the above and all of the above are usually the answers. But so here I deliberately brought in a certain level of ambiguity. So let's discuss that.
Yeah, I agree.
It's a wrong question. This is a wrong question.
I know you'll say it's wrong. And we had a discussion, Navneeta and I. She also said it's wrong. But the audience has got it right.
So, for the sake of, you deliberately created this for a learning point. That's all.
Yes, exactly. That's the idea. You can't make a blanket statement that post-tricuspid shunts beyond infancy are likely to be inoperable. Yes, the likelihood increases, but there are many who would still be operable. So by elimination...
Just want to say, many times you see 10 mm duct, 12 mm duct and operable. So yes. in a 12-year-old, 14-year-old, yes. Humongous duct and operable. So this is important to recognize that sometimes post-tricuspid, for whatever reasons, they may remain operable.
Yes. Then we'll go to the next question. I'm sorry for that little ambiguity, but I thought it just brings in that interesting flavor. Assessment of operability in the cath lab. Which of the following is true? Basal flows and resistance are of limited value in predicting operability when compared to vasodilator tests. Okay. Intravenous sildenafil cannot be used as a substitute for inhaled nitric oxide to test reversibility. Patients who are operated for shunt lesions and elevated PVR do not have a lifelong predilection for pulmonary hypertension, even if the operation gives good initial results. Oxygen alone is no longer recommended as a vasodilator testing for assessment of operability in congenital heart disease. So tough question, but I'd like to, everybody to think about it, and we'll have a nice discussion from the faculty. We'll take a little time. It's a difficult question to digest, so give it like 30 seconds at least.
Sure.
Now, the third question, maybe the wording, even if operation results in significant decline, or if operation results in significant decline?
If when we change
I think if even is probably not.
Even if not appropriate.
Yeah. It's because of that change that we made and we didn't.
Yeah. I agree. That's probably a point that I should have corrected.
Operated first.
Okay, so shall we do the poll? The audience is good, but I'll ask the faculty to interpret this answer. Saurabh, you want to have a go at the answers? Because I think there is a differing school of thought. But I'd probably like to hear your view or Dr. Kothari's view on this, because I think you guys, you still use oxygen, don't you?
Yes, sir. We use oxygen, sir. So the choice C is quite obvious from the discussion we just had, that they continue to have that risk, even with simple VSDs, those who are operated second, third year of life. they should be seen with care later on because they may have late recurrence of PH. Point A is obviously incorrect because basal data is probably much more important than.
Very good. That's very nice.
I mean, I think all of you have taught us so well that, I mean, we can't go beyond the basal data, sir. So basal data is something which is the key when we are interpreting operability. We may or may not look at the vasodilator testing, but basal data we cannot ignore. B is cannot be used. There is there are a few studies which have shown that even this can be used. I'm not certain about whether it is a good enough data as of now that we can replace sildenafil in place of NO, but depending upon availability and in the proper context, we may use it. So that also goes out. D, yes, we know that in our settings, oxygen remains a good tool, and if we take care of those and we understand the limitations of dissolved oxygen, then it remains a reasonable tool to assess operability. Again, I'm not sure of the guidelines, but...
so the guidelines say that oxygen should not be used any longer. Yes. And that's why I have written this. And I am the oxygen non-believer. So I know that you do, but that's why the opinion is slightly divided. Maybe I can ask Dr. Taragan, Dr. Yes. Subramaniam also. What do you think, sir?
Yeah, I also think that third option is the right one. Who are operated for conditions should have, especially those who have pulmonary vascular resistance elevated, should have lifelong monitoring, and there is no way to tell that they will never have. So I think C is probably the one. Oxygen, of course, it's a running controversy. There are people who do not have nitric oxide in the lab, as well as intravenous sildenafil may use oxygen, but then it has its own limitations, and we'll leave it at that. It's a close competitor to the third. I would say.
Fantastic. I agree. So the final question is, sorry. See, incremental data has not shown that if you use over and above nitric oxide over oxygen, you change the decision. I think the vasodilator testing should not be done. Yes. I agree to that. But if you do it, then if you do it with oxygen, it's as bad as anything else. I agreed.
Also has problems. That's what sir is highlighting.
Absolutely right. That has not been tested against prognosis. So, I mean, I know I've deliberately brought in a slightly controversial point, and I feel that the audience is good to handle it, because there's no right answer in this situation.
So the message should only be one, sir. That the basal data and the clinical context is the most important thing.
Absolutely.
Yes, everything can be debated because
exactly. Yes. So let's do this last question. Which of the following recommendations would be appropriate for a 17-year-old girl with Eisenmenger, VSD, PH, fatigue on effort, class 2, and resting saturation of 85% and a hematocrit of 65%? Okay, this is her X-ray and this is her fingers. And now I'm going to ask, what are the following tests we would do? Cardiac catheterization to confirm operability, initiate pulmonary vasodilators and list for heart-lung transplant, counseling and education of the disease, pulmonary vasodilators for symptom relief. D is C plus 6 monthly phlebotomy to maintain hematocrit at 60%. So I want the audience to respond to this. This is a difficult question, but I think it's an important question that illustrates lots of good concepts here.
My bet is in this audience, nobody will say, I should not speak before they tell.
Say that again, sir.
Bias the response. Let the response come, but my guess was speak then it will bias them. So let me keep quiet.
Okay. So let's look at the polls. Vishnu?
I think nobody will say D here. Let me say.
I hope nobody says D. There are people who say D. That's a wrong answer. But we've got a very close call between cardiac catheterization and C.
And I'm surprised. So far, the audience has been very smart. But
yes, here they have not been smart.
I think there's a lot of scope for all. I thought you made a bad question, but I think you made a fantastic question, because here there is a problem. 25% people want to catheterize, 25% want to do phlebotomy. So I think you must talk about it.
That's the reason why I put this question. Okay, it might be a bad question, but I know what's been happening.
Yeah,
and you know,
fantastic.
And there's 20% wanting to do a heart-lung transplant, which is also very tragic. So, you know, so the answer is C in our context particularly. So Eisenmenger does remarkably well. Listing them for a heart-lung transplant when they are class 2 would be a disaster. And this has been happening in Indian institutions. There are surgeons who are overzealous and trying to push heart-lung transplant, and they kill them early consistently, without question, in our context. Of course, cardiac catheterization is a complete waste of time when you know this patient has, and this is exactly what Saurabh was saying, when your basal data and the clinical context are the ones that make you decide. The clinical context here tells you very clearly the patient is inoperable. You don't need to waste your time and put this risk of cardiac catheterization. I've told you that, you know, lung transplant is completely not indicated in this circumstance. Just it's talked about. It's the important thing is to talk to the family, to counsel, to give a cautious optimism to the family and not paint this as a disastrous disease, because they do rather well in today's times. Yes, they have a limited lifestyle, but they can live long. Comparatively, this prognosis is better than most cancers. And I would be cautiously optimistic and really be careful in telling them about their lifestyle, about pregnancy, about intercurrent illness, about the way they need to lead their lives, precautions, air travel, altitude, all those things are very, very important.
In short, all the non-glamorous part of cardiology.
Yes, it's really important here. And doing hematocrit is one of the greatest disservice that is being done to these patients. It increases the risk of strokes. Random hematocrit. There are very few, very specific indications when you do phlebotomy, when there are truly, you know, attributable hyperviscosity syndrome. But in general, don't try to target an arbitrary hemoglobin. And despite my saying this, I see this happen so often. It's a bit painful to see what's going on. But that's some point I wanted to bring up in this particular
And also,
question.
I would add, don't give diuretics, please.
Yes.
Any heart disease patient get diuretics.
And that would just increase the hemo concentration and make the patient worse. I think
the last point is internal surgery. You know, they don't need surgery. You avoid surgery in them as far as possible.
Yes. Yes.
So that is a cause of mortality in a lot of them. So I think this is a wonderful question and brought out 4 most important things.
Sir, one small thing, if I can add, sir. Phlebotomy also increases the risk of iron deficiency, and
that promotes strokes.
That promotes stroke, and then ineffective erythropoiesis, and there are a lot of issues related to that. So it should not be done.
So with that, we come to a close. It's been I must thank the faculty. It's been fantastic. I must thank Navneeta and apologize to her that I took over at points because I couldn't hear her, and the slides were not obvious. So my apologies, Navneeta. And of course, thank you for the students for the fantastic presentations that you've all made. You really, Sujata, thank you for the presentation and lovely participation from all the students. And of course, terrific faculty. And thank you, PHFI, for all the support that you've put together. Some last words, sir, Dr. Kothari, and just a few words from all of you, and we'll wind up.
Just thank you, and thank you very much.
And thank you, sir. I know you were reluctant. Sir?
Thank you very much. And I mean, it's always said that you never stop learning. There's one more example.
Yes. We haven't stopped learning. This case is going to tell us more as we follow her up.
Yes, that's what I'm saying. You never stop
Dr.
learning.
Taragan, yes.
Thank you. One fantastic case, fantastic group. And a lot of messages being posted on chat too. So the audience was active.
Yes.
And all the guys who presented and answered were good. So congratulations and keep it up.